Good evening, ladies and gentlemen, and a warm welcome to today's webinar hosted by the Intersex Children's Foundation of India. We're here to delve into the critical topic of approaches and strategies of rearing children with differences of sex development, with a specific focus on the social, cultural, and economic context prevalent in India. I'm Ghosh, your host for today's program. On behalf of the Intersex Children's Foundation of India, I extend a heartfelt welcome to each and every one of you. Our mission goes beyond advocacy for the rights of intersex children in India. It extends to providing support to them and their parents as they navigate their unique journeys. Intersex individuals are born with a combination of traits such as chromosomes, hormones, and genitals that do not conform to their typical ideas about bodies. While this definition is accurate, it lacks the sensitivity to explain how being intersex impacts the basics of human sex development. Typically, a female body follows path A, characterized by XX chromosomes, clitoris, labia, vagina, uterus, ovaries, and estrogen, leading to traits like breasts and hips. In contrast, a male body follows path B, with XY chromosomes, penis, testes, and testosterone, leading to traits like facial hair and a deep voice. In the journey of sex development, fetuses initially start as XX, and through intricate signals, they either continue as XX or branch off to become XY. However, if the fetus misses the signals, differences in sex development occur. This can result in variations with 40 identified types of DSD, including congenital adrenal hyperplasia, Turner's syndrome, hypospadias, and gonadal dysgenesis, to name a few. Contrary to common misconceptions, DSD is not the same as being transgender. Being transgender relates to gender identity, whereas DSD means the body doesn't align precisely with a typical male, that is path A, or female, which is path A development. Intersex people can have any gender identity or sexual orientation, with many growing up identifying as straight men or women. Our distinguished speakers today will shed light on current approaches and strategies for rearing children with DSD. We are privileged to welcome Dr. Kalpana, who is a professor and HOD of Pediatrics and Director of Center of Excellence HIV Care, Dr. Shamik, Ghosh, who is a Senior Consultant Pediatrician with expertise in Adolescent health and developmental disorders, Dr. Specialist in Endocrinology, practicing in Neotia, West Bengal, Dr. Datta, who is a Consultant and Genetic Counselor, State Coordinator of Organization of Rare Diseases in India, next, Muhammad Ali, Molecular and Cellular Biologist, Research Fellow with Intersex Asia, and Sudeshna Roy, who is the ex-chairperson and current advisor of West Bengal Commission for Protection of Child Rights. Before we commence our program today, I would like to share a few important reminders. First, kindly ensure that your microphones are muted or turned off during the presentations to minimize unnecessary background noise. Secondly, if you have any questions, please feel free to type them in the Google Meet chat box at any point during the discussions. We will compile these and address them during the dedicated Q&A session and the conclusion of today's presentations. Lastly, we would greatly appreciate your participation in a feedback survey. The survey link to which will be shared in the Google Meet chat box at the end of the webinar. So let's begin. Our first distinguished speaker for today is Dr. Kalpana, a highly accomplished professional in the field of medicine. Dr. Singhania holds an MBBS and MD in medicine from Medical College, Calcutta, and has an impressive career that spans various specialties. After practicing as a general physician for over 8 years, Dr. Singhania pursued specialization in both endocrinology and nephrology. His dedication to these fields is evident from his notable achievements, including being a gold medalist in nephrology. Currently practicing in Purulia, West Bengal, Dr. Singhania stands out for his commitment to serving his hometown. In an era where many healthcare professionals gravitate towards larger cities for career opportunities, Dr. Singhania's love and passion for Purulia is truly commendable. Throughout his career, Dr. Singhania has demonstrated not only expertise in his medical specialties, but also a deep-rooted commitment to community healthcare. His insights today will undoubtedly contribute significantly to our understanding of the current approaches and strategies for rearing children with differences of sex development. Please join me in welcoming Dr. Pankaj Singhania. Dr. Singhania, over to you. The floor is yours.
One is, as you've already mentioned, CAH and congenital adrenal hyperplasia comprises a large segment of DSD subjects. They can have life-threatening situations. So, life-threatening situations like a salt wasting crisis or a death due to shock and low blood pressure can be a very common occurrence in CAH patients. If goes unnoticed, they may die before any treatment is given to them. Another issue at birth is sex assignment. Sex assignment of the parents of a child or a neonate with a different genitalia. I would not say abnormal genitalia or a deformed genitalia, but a different genitalia, not the usual prototypical male or female genitalia, will keep asking what their child is like, whether it's a male, whether it's a female, and how are they going to name the child. So these are the two issues which must be addressed at birth. For the CAH portion of it, the salt wasting portion of it, we have to be vigilant and we have to ensure that we end up diagnosing CAH patients, especially the severe ones, and treat them accordingly, primarily with the help of hydrocortisone or steroid treatment. And for the sex assignment part of it, as our professors always used to say, if you're not sure, don't hurry. Just tell the parents that you are deciding, you have to work up, you have to understand what the internal sex organs are. The internal sex organs may be different from what they look outside. There might be different organs. There might be ovaries, there might be testes, there might be both, there might be a combination of the two. So the sex assignment and the final sex of rearing of the child may not be easy at this point of time. The parents can go ahead with a neutral nomenclature or a nomenclature which can be changed from a male to female. A deep can be made a deepa and a deepa can be made a deep. So that can be one thing which you can do at birth or maybe till the time you are able to ascertain the final sex of the child, which may depend on the chromosomal sex as well. So this is one issue which we face, very much we face. They keep asking us, every visit they ask us unless we are able to give them, and at times we are never able to give them a correct answer, whether your child is of the two known sexes. That's one issue. Then going forward in the period when we enter puberty, these children can have puberty issues. They can have an accelerated puberty or cautious puberty because of excess sex hormones, or they can have delayed puberty because of excess sex hormones of the opposite sex. So a female may have delayed breast development, a female may have no menses, amenorrhea, whereas a male can have puberty, early pubertal development. So these are the issues also which need to be addressed. This primarily happens if the disease is not identified at an early age. But in a country like ours, in a resource-poor setting like ours, in a stigmatized society like ours, I use the word with all the courage at my command, that we do not get these children who come to us right away. They come to us at different points of time in life. They might come to us with delayed puberty and pubertal issues as well. So those are the issues which need to be addressed over there. The third stage in their life comes when they decide to marry, and then the issue comes with the problems of a married life and fertility issues. These children or now young adults or grown-up adults can have real issues with fertility, real issues with their married life. They may not be able to have children normally. They may have to resort to artificial reproductive techniques, and other counselings like oocyte preservation, sperm preservations, etc., may have to be undertaken at this point of time. So, and the last point where there is a problem with these now grown up DSD children, especially the CH ones, some of these children, especially the congenital adrenal hyperplasia, when they grow old, they are more prone to obesity, they are more prone to diabetes, more prone to hypertension, dyslipidemia, cardiac diseases, poor bone health, and psychiatric issues also. Psychiatric issues, I must say, are present throughout the spectrums, especially in the pubertal period also. So these grown-up DSD children, maybe in the 40s, 50s, they may or may not have a family, but then they have these metabolic issues, which are because of the abnormalities of sex hormones in them, which is because of the long-term steroid treatments that we give to them, which is because of the neglect that, and there is a big problem with this DSD or these CH patients follow up. They do not come for regular treatment because of, again, this stigma in society. They have to come at 1 month, 2 month, or 3 month interval. They do not come. They come late. They come with stopping of medicines. They've been asked to continue the medicine. They stop the medicine. Sometimes they come in serious conditions like shock. Sometimes they come back in the whole gamut as to start from square one, as if that patient has never been treated. So this treatment off on thing continues with these DSD subjects a lot, and a lot of counseling and a lot of kind of sympathetic attitude has to be taken from day one towards their condition. We have to destigmatize the condition as much as possible from day one. For younger patients, their parents have to be taken on board. The family has to be taken on board. For patients who are adults and can take their own decision, we should start talking to them regarding their growth, regarding their growth potentials, treatment costs, regular treatment, their follow-up, their sexual preferences, their sexuality, future, fertility, and everything, anything and everything like we do for any other subject. So I think these are the issues which we endocrinologists face when we deal with these DSD subjects or subjects with differences of sex development. And another issue which we initiate but is taken up subsequently by our surgery colleagues is the correction of the genital abnormality or the differences in the genitalia. If we have ascertained that a certain patient X is of that chromosomal sex, and the external genitalia appearance, the internal genitalia organization or anatomy, we can put him into one side of the spectrum, either a male or a female sex layering, then we may decide along in discussion with our pediatric surgery or plastic surgery colleagues for adult patients that we now can move to one spectrum. Patients can have genital reaffirmation surgeries, which could be a masculinization surgery, which could be a feminization surgery. That is also a very difficult thing. It's not easily available, very difficult decisions. Patients cannot come on board with this decision at once. These surgeries are generally multi-step surgeries. They are not done in one go. Some patients have required half a dozen surgeries till they finally got a genitalia of a desire, or rather a genitalia which is suitable for his or her chromosomal and anatomical sex. So there is one hormonal part of it, there is one surgical part of it, and there is one psychiatric or a psychological part of it, and there is a societal part of it, which we all have to put together when we deal with these subjects. Very difficult area. There are a lot of grey areas in this. Very grey areas. We are not sure about certain problems which we deal with day-to-day life. We keep lingering sometimes. We'll keep trying till we come to a conclusion. And there are real issues, real medical issues with these subjects which have to be addressed.
Thank you so much for the insights, Dr. Hania, and this kind of puts the deal on the head a lot, that it's not really a simple subject, but the key thing is that we need to all come on the same table. We need to put our heads together, multidisciplinary heads together to, even if we can't find all the answers, which is really not possible, but at least we can attempt to make the lives of our children improve.
And they are not rare, they are all around us.
They are all around us.
They are not rare. We can't ignore them. We have to address them, and we have to address them in the best possible way with as many people as we need on board.
Yes. Our children deserve that. If nothing else, our children deserve that love. Thank you so much, Dr. Sonalia, for your support and for your insights as well. As we move on to our next esteemed speaker, Dr. Ghosh, would you be able?
Yeah, I'm unmuted myself. Yeah.
Sure. Thank you so much for joining, Dr. Ghosh. So Dr. Shamik Ghosh is a highly accomplished medical professional with a very strong focus on pediatrics and adolescent health. After completing his basic medical schooling from NRS in Kolkata, he's also done his postgraduate training in pediatrics from AFMC Pune as well as Institute of Child Health in Calcutta. Then further he studied at Newcastle University and Liverpool University on pediatrics itself. Dr. Ghosh currently is serving as a senior consultant pediatrician at Neotia Women and Child Care Center and also Manipal Hospital in Calcutta. His keen interest in adolescent health and developmental disorders of childhood is also evident through his executive board membership in the Adolescent Health Academy of the Indian Academy of Pediatrics from 2021 to 23. Apart from offering multiple chapters in the IIT textbooks of adolescent medicine, notably Dr. Ghosh has also co-authored the Adolescent Health Academy statement on the care of transgender children, adolescents and youth in 2023. And quite a few of our audiences over here, Dr. Ghosh, have heard of you and known about your work as well. So I welcome you and the floor is yours. Please take it.
Deep sense of gratitude and thank you, Kaushmi, for this wonderful opportunity and also to Deepanjana for having introduced me to this forum. Before I begin, I think so a round of applause and thanks to Pankaj for having taken us on a complete journey of how a DSD patient would spend his life. Thank you so much, Pankaj. And I would begin by again doing what Pankaj did right in the beginning, is to put on record the fact that we really need to get away from our reference to intersex, because, and I don't know how you will do it, but there is, because I'll tell you, the moment I put up this webinar on one of our pediatric groups, I got one endocrinologist and a surgeon who gave me a straight call and said, Shamik, what are you doing? I said, well, what have I done? So he says that you're speaking at a particular forum where, we need to refer to these patients with the correct terminology, and I've been given to understand that it's since 2006, so more than 15 years now, that the terminology has changed, right? So much for poking you about your name, and hopefully there will be some corrections down the line. But the pediatrician really as client who is encountering a child with a disorder of sexual development, as Pankaj pointed out, he is in a unenviable kind of a situation, right? Okay, because you not only are handling the physical shock of a case like adrenal hyperplasia, but you're also dealing with the mental shock of the parents. And often most of these present without any antenatal pointers. So we got to keep that in mind, that in a society where you are literally reared as one of the two genders, if you're somewhere in between and you really cannot assign a gender to a particular child who's been born, it causes immense pain, immense amount of trauma. And I'm reminded of one of my teachers, Professor Shachidananda Das in NRS Medical College, while I was doing my house job in pediatrics, and he was our professor in pediatric surgery, how much time he would spend on explaining everything to the parents than doing the actual surgery where surgery was required. So it was one of my very early career insights as to how difficult it is to manage these children. But having said that it is difficult, and having said that, we may not be able to give the best results always, yet it is very, very important as a pediatrician and for all stakeholders to develop the right insight into how to approach these particular cases. So, just for the benefit of everyone, I think we can group most of these disorders of sexual development into phenotypically apparent ones and the phenotypically non-apparent ones. That is, the ones which are very obvious to the eye and the ones which may not be obvious to the eye, and there could be something wrong in the chromosome or the genetic makeup of that individual. So, here we have certain clinical markers or clinical recognition, which is very, very important for us to do as a pediatrician when we are doing the newborn checkup once once a child is born and we've gone through the resuscitation measures. When we are doing the head to foot examination, this is something which has to be at the back of our mind, and we shouldn't try to be over active in trying to assign a gender. It may be, going on to erring on the side of caution and becoming paranoid once you have encountered the first DSD in your career, but it teaches you a lesson that what the mind doesn't know, the eyes will often miss, right? So once we got somebody where, we have a suspicion of a DST, we would have to proceed in a very proper manner. Now, just to give you everybody an idea, this gonadal differentiation, it is controlled by a number of genes, and we would talk of primarily three genes. That is the SRI gene on the Y chromosome, the SOX9, and the WNT4 genes. Now, all of us would know that the expression of the SRY, and the SOX9 gene and suppression of the WNT4 is crucial to testicular differentiation, and just the opposite, the expression of the WNT4 and the suppression of the SRY and the SOX9 leads to ovarian differentiation. Now, with this much of a theoretical background, we would obviously be looking at how to differentiate. Now, the message which I would like to pass on to almost all the audience over here is that the moment you suspect a DST, please remember we are in for a lifetime course of a multidisciplinary approach. There is no scope for me or for anybody else to leave things for a later stage. If I know that there is a difficulty in assigning gender, if I know that there is some hormonal interplay at work over here, taking care of the life-threatening conditions, I have to involve the endocrinologist, someone like Pankaj, straight away into the management of this child, and this is part of my job description. I cannot afford to say that I am going to do this at a later stage. Yes, if there is a life-threatening resuscitation, like you've got a shock in a child with a CAA, you resuscitate, but please make sure that you are taking the help of an endocrinologist. The other message that I really need to pass, and this is big, that a lot of these problems cannot be evident to the naked eye, is to routinely go in for a metabolic screening. Now, unless and until we develop this habit of metabolic screening, we are going to be missing out, and we are going to be losing a lot of these children, right? So, a metabolic screening straight away at birth, especially for the commonest thing that Pankaj mentioned about the 21-hydroxylase classical congenital adrenal hyperplasia, that is something we should be diagnosing as early as the newborn period. If we have anything that is appealing to the eye in the form of a non-fully formed male genitalia or a non-fully formed female genitalia, please let us all pledge upon ourselves the need to involve a geneticist And it's not just about sending off a karyotype. Yes, some places you will get the karyotype giving you an answer, but sometimes you need to slice up those chromosomes and those genes a little further to come to a diagnosis. So the other message is, please involve the geneticist as soon as possible. And the final message as a pediatrician, which I need to pass on, and which I think all of us must train ourselves to do, is to take care of the mental health of the parents. And we have to be empathetic towards the parents that they are going to be dealing with this lifelong. We need to put ourselves into their shoes and understand that how difficult.
Is it just me or did Dr. Ghosh's connection?
Yeah, he is not audible suddenly.
I think his network went down.
Yeah. Just give a minute. Welcome back, Dr. Ghosh.
Extremely sorry.
No worries, no worries. We were waiting for you to rejoin.
The waiting is on the next. Okay. All right. So I think so. I was somewhere around making the right referrals. Okay, and we had talked about the geneticists. The other point, like I said, is we have to keep in mind the mental health situation of the parents, and as a pediatrician who is attending to a delivery or who is the first point of contact for the parents with a problem like this, we have to be very, very careful in dealing with them empathetically. And of course, as we go down the journey, as Dr. Pankaj had mentioned, there will be various stages where the mind will be playing up as much as the body, and we will need to address them. So thank you very much. I just wanted to give an introduction as to what we are in for when we are handling a BSc. I think as we go along, we can take some questions and elaborate on anything that remains a doubt for anyone. Thank you so much. I'm sorry, I think so. I cannot hear.
Thank you so much. No, it took me a while to come out to you. Thank you so much, Dr. Ghosh, for your insights. We have come a long way in the last 10-15 years from hermaphrodite to disorder of sex development, sex to diseases of sex development. I'm sure we have a lot more scope to use and humanize this entire process and probably pathologize it less, make it less discriminatory. So, point noted, we will definitely work on that. Thank you so much. So, now moving on to our next speaker. Our next speaker is actually an intersex adult themselves. Evan Muhammad Ali is a dedicated molecular biologist and a cellular biologist by professional qualification and professional. He has a passion for vaccine research, and he's hence associated with Sangat in Bhopal as a vaccine researcher also. He's also the program officer for LBQ Women Network, and she's also a research fellow with Intersex Asia and a co-founder of Intersex Human Rights India. As an intersex, queer and non-binary individual, Muhammad brings a very unique perspective to our discussion. They have actively contributed to the field, by writing extensively on inclusion, intersex inclusion, with their work published in multiple national and international newspapers. They go by the pronouns they, them, and is a very, very prominent advocate for intersex rights, and is today with us to shed light on the challenges and experiences faced uh, by intersex people in real life. So our aim is to help intersex children, and it's very important that we understand the perspective of children who have lived experiences, so that we can really make ourselves relevant to their lives. So I welcome you, Mohammed, and I thank you for agreeing to participate in this discussion at such a short notice. Um, I welcome you, Mohammed, and over to you. The floor is yours.
Thank you so much, Shamik. Hello, everyone. So lovely seeing and hearing narrative. I just want to register my protest that it was very insensitive to hear whatever has just been spoken. A very dehumanizing way as well. And these are my opinions, of course. But others who have been intersex researchers and allies who have been present in this meeting right now will also agree with me that let's be a little more humane when we refer to people and individuals and children and not as subjects, because we are not lab rats. We have feelings as well. We have existed before. We exist now and we will exist afterwards as well. And I love using the word intersex. That is what I am. That makes my identity. That makes me complete. And no person can tell me or take away that right and energy away from me. That saying that you are not intersex, or we don't want to use this term. You're not using the term does not mean the word you want, right? So like I have the power in reclaiming that word for myself, and I'm saying intersex today, I will say that I'm intersex tomorrow, I'm intersex by birth, and I'll continue doing it. Again, this is not an attack to anyone. Please don't take this very personally. This is a general PSA out there. So the whole idea of an intersex adult, I heard to some of the concerns that were put out by our esteemed doctors here. And I come from also from a medical background as well. All of my parents are doctors, and I've grown up in an environment where I've seen that we express the solidarity, concern, and humanization to ourselves and our children, but we don't sometimes do that same. Extend the same to the people who are coming to us to take treatment. And as a molecular biologist and a geneticist as well, I look at being intersex, and as I said, I love using the word intersex. So it's not going to go away from me. So the autonomy of using the word intersex, it's not a slur, it's not a bad word. So please don't be alarmed by saying that maybe it is a slur, I don't want to use it, and I end up using a slur. So disorders of sex development is a slur recognized by American Association of Pediatrics. They said that the word disorder is harming, pathologizing word, do not use it. And who likes to hear the word disorder from themselves? Think it from a humane perspective. Would you like to be called a disorder in your life? You don't want to do that to yourself. You don't like the word itself creates an unsettling feeling in your body. It is very wrong. You should not be using that for yourself or for others. So we see that the language is evolving around. You see the words, if you pick up dictionary actually and see, intersex was used in the 17th century. So it has existed. Oh my God, it's not a new term. People have used intersex to describe various other things that have been out there, but not just medical aspect. When I say I'm from medical genetics background, we do use the word intersex in genetics as well. Some strains of flies, fruit flies, Drosophila melanogaster, are intersex. So we are using the word intersex here. It's not that we are shying away from it. So if you are using the word intersex, it's not taking the autonomy of that fruit fly. By saying that when people say that they are intersex as well, it's something of a label. It's affirming them to their identity. It's not taking away anything from them. It's not taking away their rights. It's not isolating them from something. Or it's not a bad thing. So we use labels to affirm ourselves. We use labels to make ourselves feel self-belong. Because what we face as a voice of an intersex adult, I can tell you that constantly what I've seen in my life, the medical community and other spaces pathologize you for not being the binary. You say sexes are two, but I refuse and I say that sex is binary. Sex is not binary. It is a fluid. Biology will tell you that evolutionary genetics and developmental biology, I've done all of that. And I've studied all of that, and I can tell you that it is not a fixed state. It is evolving. So as we evolve, I think our language needs to evolve and adjust as well. It's not what do I say? It's not very difficult to adopt new languages or adopt new terminologies. So imagine if you're not using a word for yourself or people you love, how is it morally or ethically okay for you to do that for others? Right? Like bioethics, where does that go in? I have so much to share, but with the limited capacity and time that I have, there are some things that I would like to list down. And again, these are my opinions. Some of them are universal truths for me and for people around me, people who are supporters, researchers, and other well-wishers of the intersex community. Is that there is a lot of unnecessary medical intervention happening, and it's the truth. It's nothing bad that you should not acknowledge it. If there is something, for example, you go to the hospital. I was at the hospital yesterday with my mom, and they came for a test, and they said that this test is important for you. DEXA scan, I believe. DEXA scan is important for you, madam, but would you like to get it done? So my mom was like, no, I would not like to get that done. It's not necessary for me, right? So you have a right to refuse there, right? So like we extend that openness and that conversation. I feel like in India, and I think this is very specific to India, is that the concept of lack of informed consent is not in India. It is a rare thing. We don't talk about it because we don't also have time to sit with our individual patient person in need who has come to sickness to tell them what can happen, what is happening. I respectfully understand and know that you are pressured by the system, you have lack of staff, you have lack of resources and infrastructure, which is prompting you to not have enough time to spend with your a person who's coming deep for you. So I do understand all of those factors and constraints, but at the same time, the moral obligation of how you want to be treated when you go and visit a doctor is the same as somebody who's approaching to you for the same need, And when, as somebody who has survived multiple doctor visits as an intersex person, I feel very important to say that kids, who are intersex and who are constantly asked to show their body in doctors and rounds of doctors for research is very dehumanizing. You might feel that they are kids. I think someone referred that we should consider the state of parents going through things, right? Right, mental health of parents. Absolutely, I think that it's very hard for parents as well. Have you thought about the child as well? Do you think what mental impact this will create on the child, to their self-esteem, to their dignity, to the basic fundamental things that make us human? Have you ever thought about that? Have you thought about how difficult it is for the child to grow in an environment? Because let's be honest about it, the pain that the child goes through is suffered only by the child alone. That pain, physical pain, the surgery pain, you as in an individual or as a parent cannot take it. My mom recently had a fracture, and I was sitting next to her and I held her hand. I said I could take her pain. That's all. You can say that to your child. Tell that I wish I could take her pain away. You cannot experience that pain that they go through. So it is important that you involve everybody, all as stakeholders in your communications. Children understand. Do not underestimate children as figures of who do not have feelings or who cannot understand enough. Children, telling you that they are in pain is a valid feeling of expression and thought. Imagine yourself in that situation when you were young and you had pain and you were dismissed. Maybe that was a bad experience for you, but let's not repeat that. Let's break the trauma cycle there and be a parent who understands and acknowledges that empathy, sensitivity is the way to go forward. And dehumanization, insensitivity, and other forms of practices that makes your child go away from you or not have trust issues. It shouldn't be like someone said, right? 40, 50 years, you have a lot of metabolical issues, right? So apart from that, they also will have trust issues, by the way. Your child will go around mental health offices seeking help because they have trust issues with you. And that is also another important factor that you have to consider. Imagine being a parent and having your child having trust issues with you. That is such a sad thing for you to honestly sort of acknowledge. And apart from all of these medical factors that are there, there is another big plethora of problems on us, that is the lack of understanding, right? So like when you deny the aspect that you don't want to use a certain word because you feel that the autonomy is taken away from that person or individual. Sure, that is your thought and process, but do not claim to that you speak for ourselves. Again, you cannot take our pain away, you cannot take our suffering away. What you experience is just a tip of the iceberg of what we are going through, as an experience, as an observation, but not as a lived pain or experience. So that belongs in the individual. It will always belong to the individual. No person in this world, including other intersex people, can take or experience that for. Something that I would like to end my discussion or talk is the idea that intersex variations or being intersex, or okay, even if you have reservations on the word using intersex, we can use another beautiful term, variations in sex level, where diversity of sex. Why should it be a disorder anyway? Let's evolve our language even in 2024. Let's be a little more humane in our approach.
I think, Pankaj, we've reached there. We're currently using the word differences and not disorder.
We still have a long way to go, Kalpana.
Long way to go. As I said, from hermaphrodite to disorder to differences, we've reached somewhere.
Absolutely, and acknowledging the fact that we have access to these terms as an existing term that people are aware of. That it shows progress. What I would like to end with saying that is that many medical organizations, if not ourselves, like World Health Organization, it is something. It is your Bible of the organizations that are out there, and sometimes we love looking at American and Western organizations as reference. So AAP, as I mentioned, American Academy of Pediatrics, they have recognized the fact that pathologizing intersex traits is very harmful. At least they have said it. It's not that unbaseless person here sitting and talking. They have said it, that it is pathologizing that you call intersex trait.
Mohammed, for your insights, and it definitely makes us think. You have actually made me also pretty uncomfortable in my chair, which makes me uncomfortable in a good way, because then that makes me think that how can I do it, and that's the intention. So, having said that, I would like to welcome our next esteemed speaker today, Dr. Kalpana Datta. Dr. Datta is a distinguished professional in the medical field. She holds the position of professor and head of the Department of Pediatrics, and also the director of the Center of Excellence for HIV Care, and she is in charge for the Adolescent clinic, also at the Medical College of Calcutta. She has a wealth of experience. She was the president of the Society of Pediatric Neurology of Bengal chapter from 2015 to 22. Following that, she assumed the role of chairman of the chairperson of the Academy of Pediatric Neurology of India in 2023. Apart from having published more than 58 papers and having authored multiple chapters and textbooks on pediatric neurology, hemato-oncology, and antiretroviral, she is also the paper setter and examiner for TCHTMB, MD, and examinations. Her expertise and her leadership makes her a very valuable contributor to today's discussion on the approaches and strategies of rearing children with differences of sex development or variations of sex development. And so we have actually requested Dr. Datta to kind of present to us on a topic which is slightly different, which is the challenges of current healthcare infrastructure in the public healthcare for the children and parents of the children who come with the differences or variations of sex development. So I have the presentation Dr. Datta has shared with me, and I'll share that on the screen as well. Dr. Datta, over to you. The floor is yours.
Thank you, Dr. Koshi, for your kind words of introductions. Very good afternoon to everyone and respected chairpersons. And really thankful that you have given me this opportunity to talk in such an important platform. Having heard about the previous speakers and especially Mr. Muhammad, I really became emotional, and we should be very sensitive to talk about. So we heard many things about the terminologies, and Mr. Muhammad also said in the 17th century BC. So I like to inform you in 17th century BC, before Christ. There is a child from the Hermes and Aphrodite, and the product is that the child was not having a typical sex. From that, the term hermaphrodite is come. Then after the hermaphrodite, the term, when we were students, we were read as an intersex. Then again, the intersex is not good term and all. Then again, it is changed to ambiguous genitalia. This definition also lots of fallacies and drawbacks. Then it came to the DSD. So as he rightly said, this is not a disorder, and all the cases cannot be stamped as a disorder. It should be differences in the sex development. Like when a child is a mentally challenged child or physically challenged child, we don't say abnormal child. We don't say mentally retarded. We say differently able child. He may be able in a different way. So we say differently able child. These terms are very important. And when yes, sometimes when it is not fitting with the typical progression, typical what we are seeing, the typical presentation, typical features, we might say atypical genitalia. So it may be not typical or atypical, or maybe the differences in the sexual organ. So the accepted term nowadays is the DSD, and that is a difference in sex development. And as the previous speakers said, they present in any way. They are with us, they can present in the later period, they can present in the newborn period. And the first question asked by any parents when there is a delivery, what is the sex of the child? And when you are not in position to say the child is male or female, that is called psychological emergency. We have lots of emergency, medicine emergency, surgical emergency, and this is one sort of psychological emergency. So what to say, how to say, and how to counsel the parent, that to be a point to be learned. It is not a British language that you read in one day and you deliver. It is the learning process. We have to learn how to counsel the parents. This is very important. And as already the endocrinologist said that they present in the newborn period, but it's very important if you have an external genitalia which is not typical. This is the very easy to identify. This is not typical. You go for the different lots of investigation, a battery of investigation and all. But sometimes, like in a male child, they don't present with the external abnormalities. They can present with any shock. So very difficult unless you are aware of that. So you have to have a knowledge about it. So when we talk about the sex, as I am dealing with HIV for the last 10-12 years, these issues are very common for us, and lots of issues we do feel. So we know there is a genetic sex like XY, XX and all. Then there is a phenotypic sex, we say, like then the gonadal sex, what is the gonad inside the body, and third is the phenotypic sex. But there is another term which we should not forget, that is the psychological sex. Though the gonadal sex and the genetic sex is the male and the psychological sex is the female. So he or she has every right to choose their behavior or choose their identity as they wish. So it's very important to take care, give the importance and respect to the psychological sex too. So as I was given the topic, the challenges faced by the healthcare infrastructures in the public care, it's very important because we do face, and especially in India, there is a lots of problems addressing the needs and challenges of intersex or DST. Individuals, the public healthcare infrastructure, not only the management, It is the interplay between the medical, ethical and social factors. So we have to consider medical issues, what the child is having and the person is having, what are the ethical issues and the social factors. I am really happy, Doctor, that Mr. Muhammad also said the informed consent. This is a very important aspect to talk. As in we are dealing with HIV patients and HIV pediatric patients also. So we are very well versed with the informed consent. Always we talk and we take the informed consent and assent also. Below 12 years, you have to take the permission from the child. No one bothers to take the permission from the child. That is the issue. So these children who are having DSD or as they said, the intersex physical sex characters do not fit in typical binary notion, and they are having a lots of challenges in their life. So there are constraints in the capacity, constraint in the access, constraint in the equity issues. India's public healthcare system marked by significant capacity constraints. We have a lot of constraints, including the insufficient healthcare facilities, shortage of medical professionals, limited resources. There is significant disparity in healthcare access, both in quality between the urban and quality and quantity, or the accessibility of the urban to rural areas. And of course, different socioeconomic groups, different marginalized communities often face additional barriers to accessing the healthcare services. Now, lack of specialized services. As we know that there are multiple problems might be there, not only the external genitalia, there may be problem the internal genitalia, there may be the psychological issues, there may be social issues, there may be emotional issues, there may be occupational issues. So, there should be comprehensive healthcare. The Indian public healthcare system generally lacks those specialized services, and that is tailored to the need for the intersex individuals. There is a dearth of medical professionals which are training and expertise to provide the nuanced care and intersex condition required for the particular child, and of course the counseling and psychological support. All the medical personals or what we are always busy in treating the patient and all, we don't consider about the counseling and psychological support. It's a very important part of one of the important part of the management of any case. As a pediatrician, we say 90% is the counseling, 10% they require medicine. So, and while doing the practically, we see the total amount of time spent for a child is 90% on writing the medicine, 10% of counseling. It should be reversed. So, the need for comprehensive care is very important as counseling and psychological support, maybe hormonal therapy, maybe surgical therapy, maybe constructive plastic surgery, maybe constructive surgery, maybe psychiatric treatment. So it is a multidisciplinary treatment, and that is fall short in providing integrated and comprehensive care in the public sector. There are medical challenges, lack of awareness and education among the healthcare providers, because there are lots of questions, queries still there in the medical professionals. They are not able to differentiate between different issues. What do you mean? They sometimes confused with intersex, transgenders, the lesbians, and the LGBTQ, what we say. So you must know the exact terminology. You should have a knowledge about this type of terminologies and the issues. There are because there is no training on that, no awareness, no seminar, no workshop is that, and so they are misdiagnosed. Inaccurate treatment was given, a lack of support for the intersex individuals and their families. And as Mr. Muhammad was telling, informed consent is a very important issue. We should take informed consent. Ethical concerns arises when studies are performed on intersex infants and children. And at that time, children too young to give consent, aimed at making their bodies fit the binary gender norms. These decisions are often made by the parents and the doctors without considering the future wish or the psychological well-being of the individual, because they don't consider the child as they have a wish. As I'm really impressed by Mr. Muhammad's deliberation that he has highlighted these issues, because we should consider the particular child who I am dealing with, what does he want, what is he as a, let him be grow, let him give the environment, let him empowered to take the decision. Then only he can take the decision. Then the social and cultural stigma. The stigma and discrimination can exacerbate the challenges faced by the intersex individuals in the healthcare system. This can lead to reluctance in seeking medical care, lack of trust in the healthcare providers, and inadequate support for health issues related to the intersex. Then, of course, as is the private sectors and the public sectors, is a huge number. They are dealing huge number of patients daily. So, privacy and confidentiality concern. Every patient person has right to keep their things private and confidential, and every doctor has to maintain the confidentiality. It's very important to maintain the privacy and confidentiality for the particular individual. So, intersex individuals may face breach of privacy and confidentiality within the healthcare system, with sensitive information about the sex status being disclosed without their consent. Need for support system. The importance of psychological and social support for families and children are lacking in healthcare system. If they come with the kid, we are busy with looking at the kid, what's the problem and what is the defect, what is the pathology, embryology, and the clinical features, investigation, all this. We don't need any attention to the parents who are having this child since birth. Consider the family consent treatment should be given, and the families to be taken in account while counseling the parents. So there is a role of legal and policy framework. The legal and policy environment in many regions may not adequately protect the rights of intersexual individuals, impacting their access to appropriate healthcare and their ability to make informed decisions about their bodies. It's very important. Need for policy reform is there. So we have to form the particular policies, and in 2014 there is a policy taken for the intersex of the Government of India Supreme Court. Health insurance and coverage issues are there in case of infrastructure. So the public health, there can be significant barriers in accessing healthcare services because it's very costly, and if they don't get the health insurance and coverage, then it's very difficult to manage. Due to the insurance policies, they do not cover the treatments deemed non-essential or cosmetic, which may include surgeries or treatment related to intersex conditions. So, what is the current initiative and positive developments that we can see? There is a webinar is organized by this. I'm really happy that we people have organized such important webinar. This sort of webinars and the discussion should go on. Medical guidelines and advocacy. There has been growing advocacy against non-consensual medical intervention on the intersex children. Initiatives aimed at improving the medical professionals' understanding about the DSD. Awareness campaign should be done, and ongoing awareness campaign or NGO should be appreciated, should be highlighted. Various NGOs and advocacy groups are increasingly focusing on intersex issues, conducting awareness campaigns, providing support to intersex individuals and their families, as people are doing. So, recommendation for improvement, there is always a chance to improve ourselves, always the way to improve ourselves. So there are some recommendations. There should be improved medical training. So all the medical personnel should be trained how to deal with this type of children or the persons who are coming with the intersex and all. Emphasize the need for specialized training for healthcare providers in all category of staffs. Policy reforms, call for legal and policy changes to protect the intersex children's rights. And of course, the community support. Without community support, anything cannot happen in the society. So we need to have a community support. The role of community and the social services in providing support to intersex children and their families must be there. So in conclusion, I would like to say that addressing these challenges requires the comprehensive policy reforms, increased awareness, education of the healthcare providers, a shift towards the patient-centered care that respects the rights and autonomy of the intersex individuals. Advocacy and support from intersex community as we are getting, and human rights organizations continue to play a crucial role in pushing for changes that acknowledge and cater to unique healthcare needs for intersex. Despite these positive developments, intersex individuals still face significant challenges, including the discrimination, lack of understanding, and the risk of non-consensual medical interventions. So, advocacy and awareness efforts are crucial to continue pushing for comprehensive rights and protection for the intersex people globally. Thank you for giving me this opportunity. Thank you.
Thank you so much. Thank you so much, Venkateshwar. Thank you so much, ma'am. It really helps us understand better. We will move on to the next speaker. One second. Dr. Deepanjana, are you there?
You just stopped screen sharing.
Yes, I'm here. Just 1 second, let me stop. Hi. So thank you, Dr. Deepanjana. So now we have our next esteemed speaker, Dr. Deepanjana Datta. She is a distinguished consultant and a genetic counselor, serving as the state coordinator of the Organization of Rare Diseases of India. And with over 14 years of impressive career journey in human genetics, she has made significant contribution in the field that we are discussing today as well. As member of the Women's India Chamber of Commerce and Industry, which is Vicky, she's also the principal of the postgraduate diploma course on early intervention for neurodevelopment disorders. And she has published more than 15 peer-reviewed papers, including contributions to PNAS and Kidney International. And she holds a patent on biomarkers for metastasis for carcinoma, underscoring her dedication to advanced medical science and research as well. So I welcome you, Dr. Deepanjana, to this webinar, and I hand over the floor to you. It's all yours. Please take it away.
Thank you, Koshmi. Thank you so much for having all of us over here. And thank you so much to arrange this webinar so that we could speak on such an important topic. And it was wonderful to hear Dr. Pankaj, Dr. Shamik, Dr. Kalpana, and also Mohammed speak regarding different aspects. What I will speak right now might overlap a few, but also bring out certain concerns which is important regarding this aspect. So I'll just share my screen. Take 2 moments to share my screen. So I'll divert from exactly what my topic was, that child rearing from prism of genetics. I'll discuss genetics as such because all my predecessor speakers, they have spoken about it, but just because I'm speaking on genetics, like when we talk about genetics, we need to understand few terms like chromosomal sex, gonadal sex, phenotypic sex, and maybe more than that, the psychosocial sex also. But to limit the conversation, chromosomal sex, gonadal sex, and phenotypic sex, this is where we would talk about genetics. So, because we know that every fetus has a bipotential chance. So, first is the chromosomal sex, where it is a determination whether this particular fetus has a XX or an XY, which directs the gonads towards the functional part of it, which is the ovaries and the testes, where the other genes have to work. If we make it more simple, it's basically that first is the determination and second is the differentiation. So anything going wrong in this axis, there are about right now 250 genes which are actually involved in this axis, and every day new genes are added or new methods, new concepts are being created, and any problems in this particular axis would actually lead to what we call as a disagreement between our biological sex and what sex our phenotypic sex. So, without using much of the terminologies, if we very scientifically try to classify, then there can be problems in the numbers of X and Y chromosomes. There can be problems in the functionality or the development, which will be due to the genes. And because of these, there can be certain phenotypes that will be developed, which is different from what is supposed to be in what we call as the normal. So also there can be use of certain drugs. It might not be a genetic mutation as per se, but certain mutations that can actually change the what we are looking at. And there are certain androgenic drugs that can change and cause a female male who is androgenized. Similarly, in case of unandrogenized male, it can be a failure to produce the testosterone or failure to use, and there can be a number of dermatologies and number of genetics involved and a lot of difficult terms involved. But let's just have an example of what happens. Now, say I'll start from prenatal, that is when the child is inside the womb. Many a times right now, a very common test given during prenatal screening has been NIPT, which can pick up certain of these chromosomal disorders. Now, say it picks up certain chromosomal disorders. When it picks up, it is again a choice of the parents to keep it. Unfortunately, here, though we fight about fetal rights and fetal consent, there is no consent at the moment, even though it's a very burning topic. But even though X0 female might not have any severe implications, but many a times we see that parents wouldn't continue such pregnancies. And here a simple, probably a karyotype, the diagnostics is very simple. But as this child probably is born and may be born with something which is atypical, there can be initial newborn screening if we are looking at Western population, which can pick up conditions like CAH. But many a times the non-classical forms or the rarer forms will not be picked up. Initially, the clinicians would probably restrict themselves to a chromosomal study, and looking at the other clinical parameters may go into deeper genetics. In India right now, the problem is genetic study is very costly. So if I just say to a patient that, I need to do this study, as Mohammed was pointing out, there's a consent. The consent is also, even if the patient wants it, it's also financial. So sometimes my diagnosis has to wait. And sometimes even if I do a genetic study, my diagnosis is not full and I might need additional testings and I might arrive to the diagnosis. In an Indian setup, this is a bit difficult in for 2 to 3 reasons. One reason is that the cost of the test, number one. Second reason would also be if I am not counseling the patient over here, the need of the test is not clear, number one. How this test is helping me in my later treatment is not clear, number two. Number three, I also am creating a taboo that not only this is an atypical gender which I am looking at, but I am also looking at a genetic disorder. Now, all of these words have a lot of value and a lot of taboo and a lot of psychological impact. It's not easy to give this in one session, and hence genetic counseling is extremely important. So probably it starts with a diagnosis. Sometimes diagnosis is not easy. It starts with risk assessment, family, psychosocial support. Also here, what is very important is the awareness. Awareness in a language which the patient understands. If I am saying it in a language which is very fancy or I'm saying it with very difficult medical terms, it is not useful for the patient. Also understand everybody is scared. As somebody pointed out, nobody wants to call something a disorder. Yes, nobody wants it. But then if an information has to be given, we cannot lie to. The information has to be given. If we have to give that, we have to be sensitive, and here sensitive means the right kind of implications, the right kind of awareness, connecting to similar kind of families so that they can be assured, and this does not happen in one day. Second is, giving them a roadmap. So if I make a diagnosis and I don't give a roadmap, then my journey is then this patient is basically someone who will suffer. Because if every day I get a new test, and if every day I get a new diagnosis, and if every day I'm told to do certain new things, I as a person will get very uncertain. So facilitating communication, letting me know that at this stage I have to go for all these referrals, and this will probably not be done by one single person, and I have to visit 5 different doctors, is very essential. Now, as a child, I also understand that here there are few very difficult questions to be answered, which first I will take it as, whom are you disclosing the diagnosis to? In India, like when I counsel, I have at least 4 to 5 people in my chamber when I'm giving out any diagnosis. The first consent that should be taken is of the parents as to who should be inside the room. Whom are you giving the diagnosis to? Personally, this is something which should be done in a way that the mother and the father both get their rights of people inside. But it also shouldn't be done in a way that this family becomes a taboo and they have to answer questions to the relatives. Because we live in a society where many a times the relatives also come in. As far as consent is concerned and consent of testing is concerned, even today itself, while I was suggesting, I had a case where there was a fetus who was with flat facies, not related to what I'm speaking now. But when we said that, see, if it is genetic, then we have these conditions. If it's isolated, then surgically we can intervene and do this and that. This patient, the first thing she said, "Madam, what would you do if this was your baby? What would you do?" So understand here, what I would do was not important, and if I answered that, that would be wrong. It's not me. It's the family. I am not in their shoes. I'm not in their financial zone. I'm not in their social zone. Neither I am in their religious zone. Neither I am them. I have a different social and the way I am brought up, my exposures are different. But as a person who is sitting on the other side of the table trying to get this information, I have to be very open and very neutral. Hence, my ethical considerations over here also has to be very neutral. So, if a parent wants 5, 10 of their relatives to come in, I need to be open and I need to be able to explain them the same thing. Similarly, if the parents want nobody to come in, I need to be in that zone to let that happen. I once had a couple where the child was initially declared as a male by the medical team who was handling the delivery, and then later they changed that the child was female because the child had a condition called congenital adrenal hyperplasia. Now, the mother, contrary to the disease, the mother couldn't actually take it. The mother completely detached from the baby, wouldn't breastfeed, but the father picks the baby up, and the father till now, I'm talking this about 2-3 years back, the father till now is rearing the child. And the mother has completely detached herself from this family. So understand, giving a news, 2 parents might react in 2 different ways. So talking to them individually before giving a diagnosis is also extremely important without making this an anxious system. Also, at the same time, as I said, once they are settled with the diagnosis, we should talk about what they are supposed to do and what is going to happen in the next few years of their life, so that the coordination of care, and they are not told things every single day. So one of the things which I was saying was difficult was gender assignment, and for an adult or even a child who is like 5-6 years, to talk about this becomes very easier. We understand that the chromosomal sex might be something and the phenotypic sex might be something, and there might be a lot of things like there can be a dominant psychology that from birth the child is reared in a certain way and the child identifies with that gender. It can also be that the child is doesn't identify with that gender, but you have given a diagnosis like 5 years back. So we need to revisit our diagnosis every time as the child grows up. So it's nature versus nurture, number one. What the child is feeling, what's the child mentality towards what is happening. Many a times in the Indian society, the parents are that we have not spoken to our child about all this, the child does not need to know. But then you are creating anxiety in the child. The child is seeing 5 different positions, doing 5 different things, taking medicines, maybe landing up in hospitals, going under surgeries without knowing what is happening to the child. So again, that is not right. So involving a pediatric psychologist over here becomes very important. So it's always a multidisciplinary approach. And sometimes you need to wait and revisit your approach because the child is growing and his or her exposure is also growing. So gender assignment becomes very difficult even after the diagnosis, and this is very, I wouldn't say stressful, but it should involve the patient, the family, and everyone. And sometimes, it has to be revisited. It's extremely important. So here comes the role of psychosexual differentiation as well. So I may be a person who is a woman by both my chromosome, my internal, my external genitalia, but I might not identify myself as a woman. So understand the same thing can happen to a person who has all these issues that are growing in. Hence, revisiting the choices becomes very important. And also, while you are speaking about all of this, and while I'm not really taking the weight of this decision. Also, one of the risks that comes in is my germ cell tumor risk, because we know that all these children are also exposed to gonadoblastomas, and that with all whatever was already shared, this is another additional thing that needs to be shared, needs to be spoken to. So for the family, you receive one news after other, you receive one news after other. So you really need to prepare your family. Your family really needs to talk to you, communicate to you, and you need to communicate. Otherwise, as Mohammed said, you will start having trust issues. Your patient and the family will start having trust issues. So in the ideal world, like if we look at West, they do have a clinical coordinator who ensures that the family and the patient and the baby and the child goes through all of these multidisciplinary care, so that they have a good idea of what is supposed to happen, and they are not roaming about 5 different places. In India, once they get a diagnosis, they will go to every possible place to undo the diagnosis. So this is something that needs to be spoken to with the patient if they are looking for a second opinion. Like I, as a parent, and my child being like a child who has certain genetic conditions, I would also say that, I need to go for a second opinion. There's nothing wrong in it. But one thing is for sure, that the patients need to have confidence in what you are saying, and that confidence comes if you are confident enough to handle and give them a roadmap, and also if you are secure enough to ask them that if they want to go for a second opinion, please go and you can arrange those second opinions also. So this becomes very important. At the same time, like I have been stressing on this, that genetics involve the patient, but sometimes what you choose might be suboptimal. Why I say this? Because I'll just talk about a couple of family over here. So the child had what we call as the non-classical CAH. So obviously the decision was, if they are going for the second pregnancy, they need to look into prenatal diagnosis. The family said that this is not a life-threatening condition and we are rearing our first child. We don't want it. Maybe in our perfect world, we would want to check, and we wouldn't want, another child who has the same condition, because that's somehow, I've diagnosed, I've done this. But, for that family, it might be important because they feel that it is something I can handle and we should respect their decisions. So here, again, involving the patient, the family, what they feel becomes very important. So, why are we talking about amniocentesis and CVS? So we have been talking about a number of disorders, but one disorder in particular, congenital adrenal hypoplasia. This is a certain condition which has very high frequency in India, especially the classical form. If we look at incidence, then Chennai has an incidence of 1 in 7,000. Bombay has an incidence of 1 in 9,000, around that figure. I think Delhi has an incidence of 1 in 5,000, and the collective is something around 6,000, 6,500. But if we look at carrier frequency, because we are endogamous and we are actually getting married in the same community, the carrier frequency is 1:20. So if we are not doing a prenatal or a carrier screening, we at least need to do a newborn screening so that we can treat. There's nothing mandatory as far as government is concerned, but I guess as an NGO, this is something that can be spoken about, that can be preached, because if there is a couple who doesn't want to go through the ordeal or doesn't want to know this before, there are ways not only by prenatal diagnosis but pre-implantation, where in the embryo also we can check if there is a certain condition of this kind, and then we can go ahead. Now, we have been talking a lot about, families, like why this happened to me, what about the children, what about my, how am I going to say this to my other family members? How am I going to react to this child? What is my roadmap to this child? And if you don't bring a support group over here, like other parents who have faced the same thing, no matter how good a clinician I am, or no matter how good a pathologist I am, I'm failing. Because I'll never understand what they went through, the families, and I'll never understand what the children went through. So it's very important to bring them. Their peer group is extremely important, and hence the role of these advocacy group comes in. Also, don't underestimate the brother or the sister. What is happening to them? If we don't communicate over there, then we are also losing another aspect. That person can also have a lot of questions, which many a times does not get answered because the parents are very busy towards this particular child, or the other kid is too, in that zone that, what have I done? Why am I this way, and why is the other child that way? So there are a lot of other questions that need to be raised. Also, if you are taking a second child when you have a first child, so these questions need to be addressed, and there the psychological part becomes very important. The psychosocial adaptation, the cognitive behavior, the family system, there are different models how these can be counseled, and this becomes extremely essential. So obviously the goal, if I am a geneticist, is to do a carrier screening and test early, but if I also do a newborn screening and intervene early, because early interventions can save lives, early interventions can help families not be in that zone where diagnosis occurs so late that, there's nothing much to do. And also, it shouldn't be that, the child is harmed or we lose a child because of the diagnosis being late. But at the same time, I wouldn't underestimate, even the cases where we are looking at things which is non-genetic, because even the psychosexual part, it's extremely important. So we are probably a bit myopic when we at these kind of disorders, and it's essential that some way that we both speak together. The clinician group who actually wants to make a change, and also have a roadmap, and also have a support system where parents find, or the kids find a way they can voice their opinions and they can come forward. So this is what I have to say, and thank you. Questions are there, and we will take it.
Thank you so much. Thank you so much, Dr. We move on. Tivika ma'am, are you there? Or Sudeshna ma'am, will you take over the next topic? Hi.
Hello.
Hi. So our next speaker is Ms. Sudeshna Goel. She is the former chairperson of the West Bengal Commission for Protection of Child Rights, and she's currently an advisor for the commission. So I would welcome Sudeshna ma'am. She's been in the social services sector for a very, very long time. Her contribution in the field of protection of child rights and supporting of children has been phenomenal over the years. So would request Ms. Roy to take the floor and address us.
Thank you, Kaushami. It was a pleasure when you came and first contacted me while I was the chairperson last year, and we talked about. Now I'm a little confused on what the nomenclature should be, whether it should be intersex or DSD, whatever it is I wouldn't say a problem, it is a condition that we have to face. It was really nice and it was illuminating listening to all the doctors, Dr. Pankaj Singhania, Dr. Shamik, Ghosh, Dr. Kalyani, Kalpana Datta and Deepanjana, and of course, Mohammed. I really think that he spoke his heart out and he gave an idea which is something which made me feel that we have a lot to do. Now, it was a very medical and technical session, but when we are dealing with people, we are a small group, but when we are dealing with a larger group and, disseminating these information to a larger group, it has to be much easier and user-friendly. Now, as the Child Rights Commission advisor, I feel that we often work for all other child rights issues like, say, for trafficking, child marriage, for child labor. We are always working together with the civil societies, with the NGOs, with the other stakeholders like the state administration, the medical fraternity, the education fraternity. It has to all come together. And here too, I feel that we have a special need to come together and to decide on what initially, how to break the subject to people at large. Because we have a lot of misconceptions. When I first joined the Child Rights Commission, which was in 2017, and I went to visit SAR Home, which is an adoption agency, in Purulia, there was this nurse there who was looking after, and as I looked at the children, then she said, "Oh, this is a intersex child," and she opened the nappy, and that was just a 2 or 3 month old child who seemed to have a vulva and a kind of extended clitoris which looked like a penis. So that was what her understanding was. Now, after hearing all of you, I realize there are lots of things that people have to know, especially people who are caregivers, people who deal with children, people who deal with families. They have to be told, and it has to be told in easy terms. And for this, we need the help of you doctors to make it easier, and Kaushumi and people like Mohammed who can make it palatable for everybody. Because initially it has to be in slow steps. I remember when we had, and especially nomenclature. Years back, I worked with the IICP, Indian Institute of Cerebral Palsy, and before that, they were the ones who made people aware, and the term cerebral palsy was something that was made, I wouldn't say popular, that was made to be the nomenclature. Before that, people would just say, "Oh, she's a spastic," which sounded very derogatory. Now, the first thing that we have to do is how to address, what should be the tone, how do we go ahead with it. And for this, we require both the medical, the psychiatric and the civil societies to understand. And for that, it is not just enough to have a webinar like this. This should be taken out. This should be talked to with people, children and parents, to make them understand that they are not alone, and this can happen, but there are ways of getting over it. The positivity has to be extended to them, and I've seen Kaushumi do that when I've spoken to her, and when I first met her, that was even before she came to me last year when she had adopted a child. Now, the other thing, that how much should you tell the child and how should you tell the child? Because I am concerned with the child, it is very important. Like when you adopt a child, there is always this question, or there is this doubt on when to tell the child and how to break the news that he's not the biological child, he is an adoptive child, and how to put it across. Similarly, this kind of when children have this kind of a disorder, since there are no better terms, I would say it is a disorder. I wouldn't call it a disability. There are lots of, like even diabetes is a disorder, and you have absolutely child diabetes. You also have other disorders like I was a polio patient as a child, and for years I had to take physiotherapy, wear calipers, but my mother treated me like a normal child. She talked about how that she told me that I could do everything and I really believed in her. And I'm one of those fortunate people who has got over the affliction. I'm not saying but even parents and all of us need. And for this, it is not enough just to have one community or one particular NGO. We have to work with others as well and communicate with them. And I'm assuring all of you that we in West Bengal Commission for Protection of Child Rights would definitely look into it and try and help out as much as possible in building awareness, in building the possibilities, telling people what exactly could be the possibilities, how they could go ahead, and how every one of those children with quote unquote disorder could be a Muhammad in future. Thank you.
Thank you so much, Reshna ma'am. Thank you so much. I now hand over the floor to my colleague Neotia and take it forward.
Hi. Hello, everyone. I'm having a kind of bad cold. Yes, Miss.
I am just taking your leave because I have another meeting at 5. Please excuse me. Thank you. Thank you. It was
Thank you so much.
Thank you, Miss.
Thank
Thank
you
you
so
very
much.
much for coming here and being with us. Thank you for your words. Okay, I wish she could have stayed for a bit more because I really wanted to thank her, and it's very important the work that our child welfare boards and rights boards do, and people who work there are so passionate, which is actually quite how do I say this, heartwarming to know that children's rights are put so importantly in people's lives. Yes. So hi, I'm Neerija, and I am here as Shumi's colleague, and she asked me to make these concluding remarks for today because I have been working with the interaction of intersex persons' rights and medical and healthcare for this would be my 10th year now. So it's in that capacity that I am speaking today, and I think since we are running short of time, we were planning to have a discussion session where we can all get together and talk about how we can go forward and things like that. But since we are running short of time and we want everybody to be able to leave at the time we had said earlier, I will say this one thing. The most important aspect that has come forward today is that we really do need to work together. We need to have spaces where we can listen to each other to understand what intersex persons, intersex communities' needs are, and for the intersex persons to understand where the doctor's perspective is coming from. And I think it is only with a finely well-tuned balance that we can actually bring progress to intersex rights, not only in India, in the world, and make sure that our children have the best life they can have. That's the most important thing that we are talking about here right now. So the first thing I would like to say is that when Mohammed was talking, she was talking about how some of the words were triggering her, and or some of the language that was being used, the language used in medical and healthcare was being used was triggering. And the reason why sometimes doctors don't understand that or may not even hear that is because medical education. And for me, it took me quite a while. I was under the impression that doctors didn't care. It's not about that. Doctors do care, but they don't have access to what happens in the lived experiences of intersex persons during a life course. What happens to the children who don't understand initially, then understand and internalize trauma and then go forward. But medical education, medical training names these intersex variations as disorders of sex development and are taught, doctors are taught how to treat them. But health is no longer understood as absence of illness. It is about mental health, it's about physical health, it's about social health. And the social health aspect is the one place where we need to have the most understanding for that. And I think the question that I want all of us to have here, would be, how do we go forward from here? How do we make spaces where we get to talk to each other in a very candid manner? People get to share their lived experiences and what they would want in their lives. And doctors tell us the way that this can be done, because we are not trained medically. We don't know about what health issues we might be having, what healthcare we need. You are the ones who know that. So we need to have that talk where you tell us how we can do this, learn, teach us, and we teach you about what we need is what the community says. And right now, that lack of interaction, the space to interact outside of a doctor-patient relationship, that is a space maybe that we should be having, we should be creating, and that's what Kaushami is trying to do with the foundation. Create that space, bring spaces like this. This is meant to be one of those spaces. So maybe we can all come up with suggestions of how to do that. What would be the best way to do that? And I'm just taking a look at the time. Okay, so that is the one thing that I really wanted to talk about today. And the next thing I would like to say is that yes, it's not just about intersex persons. It's not just about intersex rights. When we talk about, we are talking about patient rights. We are talking about patient confidentiality. We are talking about the social practice of healthcare and medicine, combining it with the technical aspects which the common laypersons do not understand. And Muhammad made a very important point that each intersex person's experience is different, even if they have the same variation. So how do we handle that in a large scale healthcare system like that of India, where Muhammad herself said that the overwhelming number of people approaching and the individualized care that people need, how do we combine that? So these are things that we really do need to talk about in detail, discuss in detail. Dr. Kalpana Datta spoke about policy reforms and legal framework reforms and things like that. So all of these need to come together so that we can move forward in a very informed manner. It's not just about informed consent. We take informed decisions. We have information that is balanced and connected to from all sides. That is way to the most progress, I believe. Like, this is what I felt after listening to everyone. We all have the best intentions at heart. How is it coming out? How is it working out in real world? We need to understand what happens when certain practices are done. We also need to understand how it feels when doctors are doing what they're taught to do. Doing what they're taught is the best way to make sure a child's life is best. And then they face the community who's saying, you're harming us. How do we extend that support to doctors also? Because they might never have heard this, especially I'm talking about young doctors who are passing out now, who are learning now. They might never have the exposure. So how do we do that? This goes both ways. So I think that is something that we really do need to consider. And now I would like to go ahead and thank everyone who came here. I would like to thank Ms. Muhammad for being here, for giving us a quite robust explanation of things in a very short time. And I'm really grateful that you voiced out the community's voice here, that you were here for that. Thank you very much. I would like to thank Dr. Patnaik Sindhania. I'd like to thank Dr. Shamik Ghosh, who had to leave earlier because of an emergency. Dr. Kalpana Datta, Dr. Deepanjana Datta, Ms. Deshna Roy, all of you had given us such in-depth insights or conversations about your own specialities, and showed us that there is a need for us all to come together to talk about these things so that we can go forward. So with this, I would like to invite Kaushami back to the floor so that we can close the session now, and hopefully if anybody needs to say something, we would have a few minutes for that, which is why I'm stopping now.
Thank you so much, Neotia. Thank you so much. Yeah, we do have a few minutes, but a humble request from me to all of you, including Dr. Sinania, Dr. Datta, both Dr. Deepanjana Datta as well as Kalpana Datta, and the others, Mohammed, the others as well. Please do fill that feedback form that I've shared the link of. It would really be good to have, your inputs, suggestions on how we can improve ourselves and how we can continue this momentum and take this conversation forward. It is going to be our earnest effort that the momentum is not, stopped or obstructed in any way from there on. It's very important that now we have started the conversation, to keep the conversation going and not to, let the ball drop anywhere. Because our children really, really deserve this from us, and I think we owe it to them to make their lives a lot better. So I thank each and every one of the speakers as well as the participants. And at the same time, request you to please share your feedback with us. And yeah, we have a few minutes if anybody would want to share any of your thoughts, including the speakers, Dr. Singhania, Dr. Kalpana, Mohammed, if you all would like to share. Floor is open. In case anybody wants to speak, please go ahead and unmute yourself and speak. Sure, Dr. Datta. Thank you so much. Would anybody want to speak? I think everybody wants their tea, coffee in the evening.
I am glad we finished on time.
Yes. Thank you so much, Dr. Singhania. But the next, our learning, as far as I'm taking my learning, is that we need to have more frequent sessions and longer sessions.